Welcome to This Explainer. Today, we're diving straight into decoding the absolute complexities of CMS telehealth regulations. Navigating the nuances between video visits, phone calls, and virtual check-ins can honestly feel a bit like walking through a minefield. But by the end of our time together, you're going to have a crystal clear understanding of the rules. We are going to empower you to code accurately, maximize your rightful reimbursement, and most importantly, build a rock-solid shield to protect your practice from targeted audits. Okay, let's take a quick look at our syllabus for today. We'll be moving through a telehealth EM overview, audio-only rules, virtual check-ins, POS and modifiers, and finally, surviving audits. Let's jump right in. Section 1, Telehealth E&M Overview, defining the technological foundations. Before we even think about looking at a specific code, we have to truly understand the technology transmitting the service. Telehealth broadly falls into two categories. Synchronous just means it's happening live, in real time. It explicitly requires a two-way, interactive audio and video connection between the provider and the patient. Asynchronous, on the other hand, is what we call store and forward. Think of a patient snapping a picture of a weird skin rash and securely messaging it to their dermatologist to review later in the day. So the absolute crucial takeaway here is that if you want to report standard outpatient evaluation and management codes, those 99202 through 99215 codes you use every single day, CMS requires that live, interactive, two-way audio-video connection to be fully compliant. There are literally no exceptions. Now, CMS categorizes these remote services very strictly. Standard synchronous audio-video services for your 99202 to 99215 visits sit right at the top of the hierarchy. But it's super important to understand that audio-only telephone encounters have their own completely separate category and code set spanning from 99441 to 99443. And sitting even further down the ladder are virtual check-ins, isolated under code G2012. Figuring out exactly where your specific patient encounter falls in this CMS framework is step 1 to clean, accurate billing. Section 2, Audio-Only Encounter Rules. Mastering codes 99441 through 99443. So, what happens when the video fails, or the patient simply doesn't have the tech capability for video call? Well, we turn to audio-only codes. Code selection here relies entirely on strict, exact time increments of medical discussion. You do not use medical decision-making to level these codes. It is purely based on the clock. For 5 to 10 minutes of medical discussion, you're going to report 99441. If that call extends to 11 to 20 minutes, it's 99442. And for a 21 to 30-minute deep dive over the phone, you report 99443. Keep in mind, services consisting of less than 5 minutes of medical discussion are simply not reported. But here is exactly where providers constantly get caught in CMS's famously rigid web. There are incredibly strict exclusions for these telephone codes. I always tell coders to remember the rule of 3 for these guardrails. First, the call absolutely must be initiated by the patient or their caregiver. Second, the call must not originate from a related EMM visit that happened within the previous 7 days. And third, the call must not lead to an in-person or full telehealth EMM visit within the next 24 hours or the soonest available appointment. If a call violates those 7-day prior or 24-hour post rules, you just cannot bill these audio-only codes separately. The work simply gets swallowed up and bundled right into the associated EMM visit. Section 3, Virtual Check-ins Demystified, Distinguishing the G-Codes. CMS differentiates these quick, brief communications from standard telehealth visits using specific HCPCS G-codes, and there's a stark contrast here. G2012 is a live, brief virtual check-in. It's exactly 5 to 10 minutes of medical discussion with an established patient specifically intended to determine if an in-person visit is actually necessary. Now, if you end up needing a bit more time to make that decision, there is also an extended virtual check-in code, G2252, which covers 11 to 20 minutes of medical decision-making time. On the flip side, G2010 is strictly an asynchronous remote evaluation. This is when a provider reviews patient-submitted recorded video or images, like that skin rash analogy from earlier, with provider follow-up required within 24 business hours. But tread carefully here, guys, because these check-ins also carry those strict 7-day prior and 24-hour post-bundling rules. Always watch your dates of service. Section 4, POS and Modifiers Masterclass, Applying Rules to the Claim Form. Place of service, or POS, tells the payer exactly where the patient was physically located when they received the remote care. For a long time, this was a famously confusing area, but thankfully it's been streamlined into two main choices. POS 10 means the telehealth service was provided while the patient was in their own home. Utilizing POS 10 correctly is absolutely vital because, for most CMS and commercial payers, it aligns your reimbursement with the higher non-facility rate. Conversely, POS 02 is used when telehealth is provided in a hospital, a clinic, or literally any location outside of the patient's home. Choosing the wrong POS here will directly impact your practice's bottom line. Right, next up, we have to tell the payer exactly how the service was delivered using modifiers. You never want to confuse these on your claim form. Modifier 95 indicates a synchronous telemedicine service via real-time interactive audio and video. Append 95 when you have visuals, when you can actually see the patient and they can see you. But if you're doing a telephone-only EM service, modifier 93, or sometimes modifier FQ, depending on specific payer guidelines, is your required indicator. 95 for video, 93 or FQ for audio only. It's a remarkably simple rule, but honestly, it's one of the most heavily audited areas in medical coding today. Let's look at how this all comes together in a few real-world examples. Take a new patient video visit for a rash, lasting 35 minutes with moderate medical decision-making. That codes out to a 99204. Because it was on video, we use modifier 95, and because the patient was sitting at home, we use POS 10. Now, consider an audio-only depression follow-up phone call lasting 15 minutes. That gets coded as a 99442. We apply modifier 93 because it's audio-only, and POS 10 because the patient is at home. Getting these elements stacked together perfectly is your exact blueprint for a clean claim. Section 5. Surviving Telehealth Audits. Your Compliance Shield. A perfectly selected CPT code means absolutely nothing if your documentation doesn't back it up. Every single telehealth note must hit 3 incredibly structural documentation checkpoints. First, you must obtain and clearly document the patient's verbal consent to proceed with a telehealth encounter. Second, you gotta log the exact total time of the encounter and explicitly name the technology platform used, like Doximity or Zoom for healthcare. Third, you must document the precise physical locations of both the patient and the provider at the time of service. If you miss even one of these structural steps in your provider note, your perfectly coded claim can instantly turn into a painful, unappealable denial. You have to remember, auditors rely on data mining algorithms to spot patterns, and there are very specific triggers they flag. They look for unbundling, like billing a virtual check-in when an EM visit happened just a few days prior. They constantly look for missing exact time logs on those time-based 99441 to 99443 codes. But here is a massive trap I see all the time. Be especially careful with dropped video calls. If you start a video visit but the connection drops and you end up finishing the visit on a standard phone call, you must update your billing to audio-only modifiers. Furthermore, if that audio-video connection is lost, you have to ensure the medical discussion actually exceeds 10 minutes in order to report the audio-only service. You simply cannot bill a high-level video EM if the video failed 2 minutes in. So the real question you have to answer is this. Are your current electronic health record templates actually robust enough to force compliance and survive a targeted CMS telehealth audit? Take a hard look at your practices today. Update your templates, train your providers on the 7-day rule, and master those modifiers. Don't forget to like, share, and subscribe to Decode Healthcare with Herschel.